ICD-10. All right, so we're going to go ahead and move the slides, and it should be moving now. Let's talk about we're first going to talk about diagnosis coding, and we're going to review the ICD-10-CM official coding guidelines as we go through and talk about some of the different key areas. I'm also going to be using my TrueCode encoder just so we can look at the codes and see what they look like, and as we go through the diagnoses, and then a little bit about the inpatient procedures before we finish up today. So we're going to start off with ICD-10-CM, and that's Chapter 5, the Mental, Behavioral, and Neurodevelopmental Disorders, and those range from F01 through F99. And remember that you want to be really particularly aware of the Exclude 1 and the Exclude 2 notes, and we'll look at those in just a little bit. Now remember, with these, we want to make sure that these are divided in different areas. So when you're looking at diagnoses for psychiatric diagnoses, you really have to look at the what's causing it, because what is causing it is going to make a definite difference in which code is appropriate. So if you have a mental disorder that is due to a medical disorder where they've had a head injury or something like that, that's coded very differently than if they just have a personality disorder all by itself. So it's very, very important to make sure you're looking for etiology in the documentation, and also make sure you let your physicians know that it's very important to document due to, caused by, associated with, those kinds of things. So at the beginning of the first block of codes in the ICD-10-CM code book under the F characters, the first note it tells us is that if you do have those that are due to a medical disorder such as cerebral disease, brain injury, or other type of thing leading to a cerebral dysfunction, then that is going to be coded here. So it talks about diseases, injuries that affect the brain directly and selectively, or those that are secondary, as in systemic diseases or disorders that attack the brain as one of the multiple organs or systems of the body that are involved. So that's a very important note there. Now this just shows you a page out of my TrueCode encoder what the code book looks like. And again, when you're looking at TrueCode, you will see the book as you're looking things up. And I just looked at the first one, which is the F01, which is a vascular dementia. And you can see there's the note that we were just talking about. It's right there in your code book, whether you're coding from a paper code book or using the encoder. You should see a note right there under the main part with the F01 through the F09 range. And you can see it's very specifically just like what we talked about. And then you can see as you go through, it says it is a result of an infarction of the brain due to vascular disease. And then notice this code first note. Oops, let me go right back to that one. The code first note here, it says code first the underlying physiological conditions or sequela of cerebrovascular disease. Now, a sequela is a late effect. In other words, this patient had a stroke several years back, for example, and they still have dementia, and it's due to that previous stroke. So that's going to be a sequela of the cerebrovascular disease, meaning that that code will be coded as well. And so watch those are going to be found in the G chapter or the neurology chapter of ICD-10 if you need to find those particular codes. When it says code first, the code first note is an instructional note, and it is a sequencing note. You have to code the underlying medical cause first and then follow it with the code from the F chapter. So whenever you see a sequencing rule like that in the code book, it is very important that you do follow the sequencing order. You can also see with a lot of these codes, they are going to be divided into what else do they have. They have vascular dementia showed by code F01.50 and F01.51. But notice they are either with or without behavioral disturbances. Again, very important as you're going through and thinking about in your practice or in your facility, do you have documentation that would support that? Do they say behavioral disturbances? I think it's very important to make sure that we're sharing this information, if we haven't already, with our physicians and our other clinicians to make sure that they know what we need from them, the things that are different in ICD-10, very important there. Now, these that are due to other conditions, most commonly those are going to be dementia, delirium, mood disorders, and personality disorders. Again, remember that if they have a personality disorder that is not due to another condition, that's in a different chapter of the book. Here's the F2 codes. There's dementia, and notice this one says in other diseases classified elsewhere. It's the same thing we just saw, but just a little bit of different terminology there, and there's a really long list here of code first, the underlying physiological conditions such as. So it gives you example. And when it says such as, of course, that's not a complete area, but it does give you a lot of choices there. It tells you a lot of the different codes. And again, there's that code first instructional note to make sure that we're coding those first, and then follow it with the F02 code as appropriate for that patient's condition. Just a little further into the code book, here you see the F03, unspecified dementia, which is further specified into F03.90, unspecified dementia without behavioral disturbances, and then with. And then you can see that if it's any kind of aggressive behavior, combative behavior, or violent behavior, those all included here. Now under the F03.91, notice there's another note, use additional code if applicable to identify wandering in an unspecified dementia. So that's a note when you see use additional code, that means code this one first and then follow it with that. So in that case, you'd actually have three codes. You'd have the actual medical condition first, then the F03.91, and then the wandering Z91.83 code as appropriate. So it gives you a lot of rules and notes about what comes first and how you'd use it from there. Moving on to a couple of other things, here's some of our mood disorders. Now you can look at the definitions here in the detail level there. What else is going on? It's due to a known physiological condition. It's common in all of those, but then it also shows that that basically it's got what else is going on with depressive features, with major depressive-like episodes, manic features, or mixed features there, all of those. And so you might want to have conversations with your practitioners about how would I know that? What would you say? What does that mean, mixed features? Talk to them about their documentation from a clinical perspective so you'll be more comfortable with the codes that you're assigning there. Down here in the F07 is a personality and behavioral disorders due to a known physiological condition. Again, there's that code first, the underlying physiological condition. Etiology and manifestation coding, here's another one of our notes from the official coding guidelines reminding us about many of the things we have just been talking about. Code first, use additional code, and in diseases classified elsewhere. All of those mean there is an underlying condition and then also manifestations. Again, you want to look at the notes to say code first or use additional code, or in diseases classified elsewhere also typically tells me that that code would be assigned second in the sequencing ruling. It tells you just a little bit more about the manifestation codes. Again, it just really focuses on that in diseases classified elsewhere, and we've already looked at the F02, and so I think we're pretty comfortable with that. So we're just going to go on and move on to our next topic. Let's go ahead and talk about the due to psychoactive substance use. So now we've got those same kind of disorders and others that are due to either alcohol or drug abuse and dependency. And so we're going to talk about abuse, well, excuse me, first off it's use, usage, then abuse, then dependency in that order. And there is a hierarchy of those codes when patients have multiple things going on or having issues with multiple substances. So if the doctor documents that their problem is due to, related to any kind of alcohol or drug abuse, you need to look at these codes and make sure that you're coding these first and follow the instructions. Now in these cases they talk about with delirium, uncomplicated versus unspecified. And again, remember your code book is designed to be a kind of a three-part process. Looking it up in the alphabetic index first, trying to find from there, it's going to group it and put you into a code here. And then you verify the codes here, and then you're using the official coding guidelines. So this one, F10.12, is alcohol abuse with intoxication. So we really do want to see that kind of terminology from our doctors. If they're talking about alcoholism or drug dependency, that's going to go to the dependency code as opposed to the abuse codes. So again, just because a person comes in intoxicated does not mean they're abusing. It just means they're using, maybe this is a one-time thing. We just don't know, and it's real important to be careful with the way we're interpreting the physician's terminology and turning those into codes. If you look down at the F10.15, alcohol abuse with alcoholic-induced psychotic disorder, those are divided into what type of disorder. Are they having delusions? Are they having hallucinations? Or we don't know. They just said it's a psychotic disorder and they relate it back to the alcohol-induced. And so you'll see here we've got with other alcohol-induced disorders, anxiety disorder, sexual dysfunction, sleep disorder, and other things as well. And again, your alphabetic index is going to give you your defaults. It's going to tell you what if they just say alcohol abuse with intoxication. Where do I go? Is that uncomplicated or is it unspecified? And typically the default is going to be to the word that says unspecified as opposed to the uncomplicated. But you do want to follow your notes in your official guidelines and your alphabetic index, trusting and be guided to the right location there. Notice also it has appeared to use an additional code for a blood alcohol level if applicable, and it gives you the range of codes or the category of codes there. In the code book, when you see a dot and then a dash there, that basically means that's referring you to the whole category. It's not just one code, it's multiple codes in that area that you need to review to make sure you're coding the right thing. Here's a little bit more about the official coding guidelines. And remember, the official coding guidelines are required by the HIPAA law. Now, I know typically when we talk about HIPAA, we talk about the fact that HIPAA is privacy and security. But also remember that HIPAA also mandates and governs the use of the codes. And it does tell us that anyone who is using the ICD system is required by that law to follow these official coding guidelines. Now, you will typically find the official coding guidelines in the front cover of your code book or in your references section. And again, with TrueCode, we have it there in the references area, so you're going to see them as you're going through the coding system. So it talks about what about remission? What do they mean by remission in mental and behavioral disorders due to psychoactive substances? So it basically says it's due to the provider's clinical judgment. So we need to make sure that the doctor has documented as such before we are able to use that. You can see here is under alcohol dependence. Alcoholism would go here as well. And here, there it is again, uncomplicated, in remission, or with intoxication. And then that particular code is further divided, just like we saw in the alcohol abuse, uncomplicated with delirium or unspecified. So again, lots more details, but the pattern kind of stays the same from the abuse section to now the dependence section. And then here we've got some exclude notes. Now up here, let's talk about those. Remember in ICD-10 that if you have an exclude one note, that is a pure exclude. It pretty much means don't ever use these two codes together. In other words, if I have an F10.1 code, I'm probably not going to code the F10.2 code together because abuse or dependence, it's one or the other. And you're going to use the highest level there. So you're not going to use those two together. So this exclude one note typically is going to be like a hard and fast rule. It's almost like a mutually exclusive edit. These two codes would never be coded together. An exclude 2, however, basically means something very, very different. Exclude 2 means is that if you if the patient also has, like in this case, toxic affective alcohol, it's not included in the alcohol dependence. Not all patients that have alcohol dependence are going to show a toxic affective alcohol, but if they do, it is okay to code the T51 codes along with the F10 codes. So that's very important there to remember. Exclude 1 means I shouldn't use these together. Exclude 2 means this particular code is not included, but you might also need it to fully identify the patient's condition. So that's a very important piece of the coding puzzle there. Now, a little bit more about when patients have multiple things going on. They have both abuse and dependence of the same substance. You're only going to code the highest level, and you're going to go with the hierarchy. Basically, the hierarchy says go to the highest level. So it says, for example, if they have both use and abuse of the same element or the same alcohol, same drug, then you're only going to code the highest one there. If they have both abuse and dependence, dependence is going to be the highest one, so you're only going to code for dependence, and so forth. So again, you can see that it goes use is the lowest level, abuse is the second level, and then dependence is the third and highest level of the hierarchy. Remember, we're talking about if it's one substance, and the doctor says multiple of these terms in describing that particular one substance. Here it goes on to tell us, again, this is one of the official coding guidelines, that we should only code these based on the provider documentation and also that they meet the definition of a reportable diagnosis. And basically a reportable diagnosis is one that does impact their level of care today. It causes an increase in the amount of time and effort and skill level needed to take care of the patient. They stay in the hospital longer. There's more nursing care. We're doing testing or treatment on that. Those are the kinds of things. And when it says see Section 3, reporting additional diagnoses, that is out of the official coding guidelines. And again, you can find that typically in the front of your code book or in your encoder or on the National Center for Health Statistics on their website. Okay. All right, so here you can see just an example of some of the different drugs. And again, if the patient has two different drugs, one is dependent, one is use, that's two different codes. The rule we were talking about a moment ago is only when you have the same exact substance, but it's shown or described in multiple areas there. So that's important to be able to note there as well. Okay. All right, so you can see here the cocaine use, we've got cocaine abuse, we have cocaine dependence, and then what else is going on? Just like the alcohol, with cocaine-induced psychotic disorder, with delusions, with hallucinations, or unspecified. And again, more detail level there. So very important to make sure that you're looking for that documentation and looking to make sure there's a correlation between what else is going on with the patient. All right, this shows you in the ICD-10 official, this is the alphabetic index, and so this is a question I get a lot. It's because the code for smoking in ICD-9 was like 301.5 or something to that effect. I'm starting to lose all the memory of all the ICD-9 codes that I had memorized for years, and it's starting to be replaced with ICD-10. Not quite yet, but I'm starting to get there. But I just wanted you to see that if you just look up smoking, it leads you to smoking with a subterm of passive. But if I look up smoker, it says see dependence drug nicotine. And there is a guidance that says if the doctor says the patient is a smoker, you'd need to use the code dependent drug nicotine instead of anything else, because there's smoking use, there's smoker, there's abuse, those kinds of things. And so it is a dependence. A smoker or current smoker is dependent on nicotine. So here I've just taken that a little further, and I've got dependence drug NEC nicotine, and there you can see under the subterm of nicotine, it says with any kind of disorder. It also divides it into chewing tobacco or cigarettes there as well. And I've noticed they've started putting out some notes about the other types. So basically a lot of people ask about, well, what about the vaporware type things, and what do you use that as well? Now remember, whenever you're using a code, you need to make sure you're reviewing any of the official coding guidelines and seeing if any of those do pertain to you. And you can see here in the TrueCode product, it actually puts those out there for you and shows you those guidelines so you don't have to search for it. So it makes it a lot easier for you to use. Now let's move on to a couple of other areas. Schizophrenia is one of those. That's in the area of F20 through F29. And if you look under the main term in your alphabetic index of schizophrenia, it does give you a code for that, but then it also gives you descriptive terms. So again, check your documentation, code it as specifically as possible. And I know a lot of you use the DSM books along with ICD-10, and I know everybody's trying to make sure they're, as we've gone from DSM-4 to DSM-5, how does ICD-9 compare to ICD-10? And making sure that you're using those appropriately. Remember, the DSM is used by the clinicians to be able to find a good diagnosis to match what's going on with the patient. And then that has to be converted over to an ICD-10 code now. And so you just want to make sure your process is correct there and that you're using those appropriately. All right, so here you can see, as I've moved over to the tabular part of my book, here you can see there's schizophrenia. Again, there's some exclude 1 note and some exclude 2 notes. What else should we code with it? And then you can see they're divided into paranoid schizophrenia, disorganized schizophrenia, catatonic, and undifferentiated. So again, checking with your doctors, there's more detail here than there was in ICD-9. So we want to make sure that we're coding it to the highest degree of specificity so that we can keep track of what's going on with our patients and get to the greatest level of detail possible. And again, the nice thing about ICD-10-CM is that there's always an other or an unspecified code, and so if we just get very little information, we can still code it. So that makes it nice as well. But if we do have additional information, then we want to code that as well. Now, I wanted to point these out here. For example, F22, delusional disorders. This one you can see is not further subdivided. It's only a 3-character code. It doesn't have a 4th, 5th, 6th, or 7th. I know a lot of people have been worried as we made that transition that all the codes were going to be a lot longer. There's going to be lots and lots of choices, and there are in some areas, as we've seen, but in some areas it's simply a 3-character code, and that's it. So that's all we use there. Okay, I'm still running into people that are sometimes they're thinking that all codes have to have a 7th character, and that's just not true. It depends on how the codes are set up. Most of your 7th characters would only be used on your injury codes as well. The mood or affective disorders, these are the ones we've already talked about a little bit, but these are just entities of themselves. They're not linked to or due to a medical complication or medical problem, or they're not due to drug or alcohol abuse. So these are going to be from F30 to F39, manic episodes, bipolar, major depressive disorders, and persistent mood disorders. Here's the manic episodes. If you've got a person who's bipolar, be careful of the way these are coded, because if you've got someone who has a bipolar disorder with a single manic episode, that is included in these manic episode codes here. But if it's actually a bipolar disorder without the specificity of the single manic episode, then that's going to be coded to F31, and that is in an exclude 1 note. So again, I know that can be a little confusing, but you just want to make sure that your documentation is very specific. If the doctor describes it as having a manic episode, code it here. If it's a bipolar disorder with manic and possibly other kinds of things going on there, then you're going to use the F31 codes for a bipolar disorder. So the terminology can make a difference in the way those are coded. Now, next we see in the alphabetic index, I've looked up bipolar, and you can see that is F31.9, and then you can see it's divided in lots of different areas. Lots more specificity here than we saw in ICD-10 there. So you can see there is our bipolar disorder and what's going on with the current episode there. Current episode, hypomanic, without psychotic features, and then with everything else going on, mild, moderate, severe. So we're seeing a lot of levels in the ICD-10 area where there are more information about these and showing how much information is going on there. What do we know? Do we know it's mild? Do we know it's moderate? Do they have psychotic features? Do they not have psychotic features? So all of those are included, and just a lot more level of detail there as appropriate based on your documentation. Okay, let's go ahead and move to the next area, and here is our major depressive disorder single episode, and you can see all the different things that are included there. And again, notice that if it is a bipolar disorder, it's going to be in a different area, but here you can see a major depressive disorder single episode, mild, moderate, severe without psychotic, severe with psychotic features. And then you also see in partial remission and in full remission. So with those, you want to make sure that you're checking with your doctor to find out when they talk about remission, what do they mean, and are they describing those as in remission or in partial remission. That's going to be up to the clinician area. Before we go on to anxiety, let me just mention to you that because you're all in listen-only mode, if you do have any questions, you can use at the bottom part of your screen, of the panel that's over to the right side of the screen, there is a chat feature or a question feature, either one of those. So if you'll click on the little plus next to question, you will see there is a little box, and you can type your questions in there. And as we have time at the end of the presentation today, we will be taking those questions. So I just didn't want to forget to tell you that if you do have a question today, please feel free to ask that, and then we will be glad to help you with that as we have time today. Okay, so let's move on to anxiety. Anxiety, you can see these are in the F40 through the F48 area. Phobias, OCD, post-traumatic stress disorder, hysteria, those are the kinds of codes that are under the anxiety area. So just to take a look at some of these are from the F40 area. Phobic anxiety disorders, you can see those are divided into agoraphobia, social phobias, specific isolated phobias, down, divided into animal-type phobias. There's arachnophobia, fear of spiders, and so forth. Fear of thunderstorms. I need that for my dog. He's very fearful of thunderstorms. But anyway, we have all those real specific. So it's important to take a look at the code book and just find how the different codes are divided there. Okay? Let me move on to the next slide. Here's some other anxiety disorders, panic disorders. Now you want to be careful because the word panic is found in lots of different codes. Panic disorder, panic attack, panic state, and again, you want to watch the terminology there. Anxiety disorder, specified anxiety disorder, and unspecified. Now whenever you see the NOS, like you see under the F41.9, whenever you see the NOS, that means not otherwise specified. That means that if they just say anxiety, yes, there's all these other details here, but if my doctor just unspecifies or he just says anxiety and that's all, that's the F41.9, and that's all we have to that. We're not able to code any further because the doctor does not give us more information. So NOS means not otherwise specified or unspecified. The doctor just said the patient has anxiety. I can't do anything more with it. But you see, that's the nice thing. Again, we can still code it there. Here's our F43, reaction to severe stress and adjustment disorders. This is where you have your acute stress reaction, post-traumatic stress disorder, adjustment disorder, things like grief reaction or hospitalization in children, and also specifically what's going on. It's an adjustment disorder, but how is it impacting them or how is it manifesting itself in that particular patient? Do they have a depressed mood, anxiety, mixed anxiety, disturbance of conduct, mixed disturbance, or other symptoms? So a lot of level of detail here with those codes. Now remember that the pain codes, there are codes in the G89 area, which is in the neurology section, and those areas do have pain not elsewhere classified, but basically you will find that there are a couple of codes where you might be able to use a pain code in conjunction with the mental disorders. So sometimes that can be related to psychological factors or mental disorders as well. Again, psychological or medical problems there. So you can see we have these two codes here, F45.41, pain disorder exclusively related to psychological factors, and then pain disorder with related psychological factors. It just shows you in the note. Notice that there is no note to code also acute or chronic pain under this first code because it's exclusively related to the mental issues. Down here, since it's partially or related, it says you can also code acute or chronic pain, that G89 code as well. So that makes it fine there. So again, that's just a level of detail, and that was covered in the official coding guideline. Then we get into behavioral syndromes associated with physiological disturbances and physical factors. These are our eating disorders, sleep disorders, and so forth, F50 through F59. This just gives you an example of what those look like. Of course, anorexia as a symptom, there's a code for anorexia, which is just a loss of appetite. Like cancer patients might have anorexia. So we don't want to code them as anorexia nervosa unless there is a specific documentation and diagnosis of having this disorder, this behavioral or eating disorder here, and that's anorexia nervosa. You can see it's divided into unspecified. They didn't say, they just said anorexia nervosa, restriction type, or the binge eating and purging type. So there is more specificity if we know that. You also have the bulimia code down here underneath it, and then other eating disorders, which is like pica, which is like people who eat like clay and dirt and stuff like that. Here we have things that are related to other areas like this F53, that's the postpartum depression or puerperal psychosis, postpartum depression there. And again, watch your notes, what it can or cannot be used with. And then here is our psychological and behavioral factors associated with disorders or diseases classified elsewhere. Again, we talked about that earlier, but these are going to be any kind of physical disorder, asthma, dermatitis, gastric ulcer, and so forth. So that's the physical disorder that would need to be coded first along with the this code F54. Now under F55, that is the abuse of non-psychoactive substances. So this is here in the eating disorder area where we have things like abuse of antacids, abuse of laxative, and things like that. So it fits better here than it did over in the other section. We also have the disorders of adult personality and behavior. That's the F60 through the F69. Another one of those terms that you're going to see a lot of is paranoid. It's going to be in several different areas, so you want to be real careful that you're looking at documentation issues to make sure that you're coding that as appropriate here. The F60 are specific personality disorders. The F60.0 is your paranoid personality disorder. Down here is your schizoid personality disorder, and down here is your antisocial personality disorder. So we had F60.0, .1, and .2. And again, you can see there's paranoid. You're going to see that term in several different areas here. So you want to make sure you're coding that too. Now, toward the back of the book, we do have the intellectual disabilities in this chapter, and those are your mild and moderate and severe intellectual disabilities. So it falls in the same chapter category here, F70 through F79. Again, we have the different determinations if documented by our doctors and or if they document the IQ level, that also can be translated into codes as well if you need them. And here you can see what those look like inside the code book. Okay, F70 through F79. From there we go into any kind of specific developmental disorders. Some of our speech and language disorders are here. You're probably not going to use this as much in the mental health arena, but they are in the same chapter, so I wanted to make sure we left it here as well. We will find sometimes that patients who are having issues, psychological issues, many times that will be manifested, especially with kids, in lack of speech or issues with their speech or language disorders. So that is coded here as well. The next codes toward the back of the chapter, F90 through F98, those are going to be ones that they consider to be most likely those that are occurring in childhood and adolescence, but they can be used anytime. So you can have someone who has just been diagnosed as a 50-year-old person as having ADD. You know, I think that's become more common now. We'll have kids that'll go through ADD testing, and all of a sudden the parent will realize, oh my gosh, I'm ADD as well, and so then they will be very successfully placed on medication. So even though they're in this area that says usually occurring in childhood, the note reminds us that it is okay to use this anytime in the person's life as it is an appropriate diagnosis. And some people might need treatment that may start when they're in grade school and may continue throughout their entire life. You can see these are divided into the attention deficit disorder. The type, is it inattentive, is it hyperactive, is it an unspecified type, those kinds of things. And then you can see at F91, we have some conduct disorders, watching your exclude 1 and your exclude 2 notes to look to see what you can use this with and what you can't use this along with. Okay. The very last code in this chapter is going to be your F99, which is a mental disorder not otherwise specified. It is just any kind of a mental illness. So if your doctor does say this patient has a mental illness, mentally disturbed, something like that, it's not going to be a code that you're going to use very often, but it is kind of a catch-all code. And as I mentioned earlier, that is one of the nice things about ICD-10 is that, or even the ICD system in general, is that it does have a code for everything. Now, I've talked to many of the mental health providers, and they said, you know, pretty much everybody could be an F99, some kind of, you know, we've all got something going on there. But again, I don't know how much you'll actually use it for coding purposes, billing purposes, but it's there. Now remember that there are symptom codes that you may also use instead. So like altered mental status, bizarre behavior, some of those kinds of symptoms, because we don't have a diagnosis yet, then don't forget to check those as well. So we don't want to read anything into it. We don't want to code more specifically than our clinician has actually documented. So the symptoms chapter is very, very helpful to cover many of those kinds of issues. And here you can see there is that code. Very last one of the chapter, mental disorder not otherwise specified, mental disorder or mental illness, NOS, not otherwise specified or unspecified. Okay, here shows you just a little bit of other codes you might need to use. There are some of the history of codes. Remember that history of codes, which used to be V codes, which are now in the Z code range. The history of codes are used when there is a history, something happened to the patient earlier on. It's no longer current, but we do need to show it because it does impact their care today. And it tells you here, personal history codes may be used in conjunction with follow-up codes, and family history codes may also be used in conjunction with screening codes to explain the need for a test or procedure. Now, when would you use a personal history versus a family history? Personal history, again, that particular patient has a problem, or a history of a problem. Family history is when you've got a family member who has a particular disease. Very important with diseases that do tend to run in families. So again, not every time that the doctor lists patients with personal or family history, only if those history of do impact their care today. Okay, and it says that actually the very first sentence here, it says, second sentence there, it says personal history codes explain a patient's past medical condition that no longer exists and is not receiving any treatment but has the potential for recurrence and therefore may continue continued monitoring, or may be impacting them today. Like if they have a history of abuse, they're not being abused now, but the fact that they've had this in the past may impact them today. These are the codes that you might see in these categories, and so the personal history, there's a family history right there, the Z81 category, family history of mental and behavioral disorders, and check that out because it's broken down even further than that. And then down here, you've got some other things like psychological trauma, personal history of self-harm, and so forth. So again, sometimes those history of codes can be very, very helpful in being able to paint the full picture of what's going on with the patient. And remember, that's really what we do with codes. That's what we're trying to do with the codes, is we're trying to paint an accurate and complete picture of what's going on with the patient. Gone is the day when we only coded the one diagnosis or the main diagnosis our doctor treated. And the official coding guidelines tell us to code all main diagnoses, but also any secondary diagnoses that impact the level of care for that day. So we want to make sure that we're coding as much as needed to be able to fully identify the patient's condition. Then we're going to look at the official coding guidelines for counseling. And that's going to be the Z69 code, Encounter for Mental Health Services for Victim and Perpetrator of Abuse. And so again, that's going to be divided out. I'll show you that in just a moment. And again, what you want to make sure of with all of the ICD-10 codes is that you're looking, especially in this chapter, you're looking for those documentation challenges that you should be finding now as we've made it through a couple of months now of using ICD-10. You want to really be careful of those combination codes. If those that say with or without something, how do we see that? Where is the doctor documenting that? How are we getting that documentation onto the patient's electronic record or into the documentation as needed? What types of conversations are you having with your practitioners to make sure that you're covering things? And talking to them about new terms that were not used in ICD-9 that we are using with ICD-10. And I've been doing a lot of classes with my practitioners and my mental health practitioners as well. And so they're excited about the new codes. They think it'll really help them to be able to further delineate and be able to define what's going on with the patient. There's a lot more level of detail, and they've been frustrated in the past many times by the lack of detail in ICD-9, and so they are very excited about this new system. You may be laughing and say, yeah, my practitioner may not be excited, but many of them are. And again, it doesn't mean that they have to document more. What we're saying is if you don't have much information, that's fine. We can still code it. But if you have a more detailed level of understanding, please document that so that we can turn that into a code and be able to show more specifically what's going on with the patient. They're changing a lot of the rules as far as reimbursement in the future, and that basically looking more or less that isn't looking at, hey, we're doing this procedure, so give us this much money. More looking at, are we doing the right thing, and looking at outcomes, making sure we're doing the right thing for the right patient at the right level of service at the right time. That's outcomes and quality of care. Those are the highlights for the future. Remember, everything you're coding now, whether you're doing it right or wrong or less specificity or more specificity, typically there's about a 2-year turnaround until that is turned into new payment policy. So whatever you're doing right now as far as documenting and then coding can come back, and we'll probably see it in about 2 years with the new reimbursement information. Now let's take a few minutes to look at the procedures in ICD-10 PCS. Of course, we're not going to use PCS for procedures for outpatient. Outpatient procedures are still going to be coded with CPT, so that has not changed. But if you have inpatient services, you do want to make sure that you are coding as much as appropriately exactly what's going on with the patient. Now the nice thing is that even though ICD-10 PCS does require 7 characters for each code, many of these codes, it's just one choice, and so it's pretty easy to find them. So in this chapter, like mental health chapter, I just put down the code here for psychotherapy. Now I know that code looks really weird. We don't have to memorize that code, fortunately, but that's the code for just psychotherapy. If it's family psychotherapy, you know, is it therapy of their own? You know, you need to look at these codes and make sure you're coding them appropriately. In the G chapter, that's going to be mental health, and then in the H chapter is the substance abuse chapter, and that's where you get like detox services for substance abuse treatment. And again, a lot of those only have one choice. We'll look at some of the medication things in just a minute. So here you can see I just went into my code book and I put in the alphabetic index in my ICD-10 PCS code book, and you can see up at the top in my encoder I've got the code book opened up for procedure ICD-10 PCS, and you can see I put in the main term of psychotherapy. So when I had that, it says, okay, if it's family, there's the code there. If it's group, there's a code, and then it more specifies, says if it's group mental health services, again, same code there. They're just trying to give you all the choices. If it's individual, it says to see psychotherapy, individual mental health services. So the code book leads you to the right area there. And then you can see if it's individual for substance abuse, what type of treatment are they getting? A 12-step, behavioral, cognitive behavioral, confrontational, interactive, and so forth. So there is a little bit of detail here as far as if they're getting family therapy, or excuse me, individual therapy for substance abuse. That takes you, again, remember those are the H chapter, where if it's mental health strictly, it's in the G chapter. In other words, it'll start with a G code versus an H code in ICD-10 PCS for those of you who have to use that. Here you can say I've looked up substance abuse treatment, or I just typed in substance abuse in my ICD-10 PCS code book, and under substance abuse treatment, under counseling, again, this is counseling for family for substance abuse. Note that is different than counseling family for mental health issues there. So if it's for substance abuse, that's going to be in the H chapter. Again, you can see under counseling group, there is the same kind of listing there as well as the individuals. You can get to it several different ways by looking up the main term in the alphabetic index. That's where ICD-10 PCS is fairly easy to find the code you're looking for. So let's take a little bit more detail a look at these different areas. In mental health section, every code does have to have 7 characters, just like in the medicine and the surgery section, but basically they're not quite as defined now. There's not quite as much detail. This is one of the chapters that's going to be added on to tremendously in the future. But right now, every code does have to have 7 characters. Most of them are going to end with like 3 or 4 different Z's because there's no other choices yet. So the first character is going to tell me the section it is. As we looked at, G is for mental health and the H is for substance abuse. That's going to always be one of your first characters. The second character is the body system. If there's something specific to the body we're doing, many times here it's going to be more general. The character third is going to be the root type, the type of procedure we're doing, whether it's psychotherapy, whether it's going to be treatment, whatever it might be. And then the fourth is going to be the type qualifier, and then the 5th, 6th, and 7th are kind of open for anything we might need to do in the future. Some of the different character 3s are root type that you will see. They will be psychological test, crisis intervention, medication management, individual psychotherapy, counseling, family psychotherapy, electroconvulsive therapy, biofeedback, hypnosis, narcosynthesis, group psychotherapy, and light therapy. So those are all the different areas there. Okay. The type qualifier is going to give additional specificity, but not all types are subdivided in that fashion yet. So you're going to see a Z in character 4 quite frequently there. To talk about some of the different types of qualifiers, you might see within psychological testing what types of testing those are. So there may be a different character for developmental testing, personality and behavioral testing, intellectual and psychoeducational, neuropsychological, and then neurobehavioral and cognitive status. So those are the different choices there, with the fourth character or fourth qualifier there is going to be the type. So those are different types that you'll see. Most of the time, characters 5 through 7 right now have a value of Z, which means they don't really have any specific values, but we do want to keep them in there because every code in ICD-10 PCS, and again, remember, we're only talking about inpatients here, would have a value of Z or none. So this just shows you a little bit. I wanted to show you in the code book what that looks like. So I just put an ECT for electroconvulsive therapy. Again, I'm still in my code book for procedures. It's very, very simple to look these up in TrueCode. So you can see here's the main term, electroconvulsive therapy, and you can see there's the main term, and then it divides it into what type it is and if it's multiple seizure or single seizure. Those are all in the G section there, and you can see that they're very similar to each other, but just a little difference depending on what type of seizure it is. So that's one thing, that if you're doing these, you want to make sure that you have documentation to support the level of specificity required in these codes. The last section we're going to talk about today is the substance abuse treatment section. And again, the same way, it's not really built up very much yet. It should be fairly easy to find the procedure codes that you're looking for. And you can see there again, the first character is a section, and that's typically going to be the H for the substance abuse. The second character is the body system, not really much specific there. The root type is the third one. That's really where most of our choices are. And then the same thing, fourth is the type qualifier, and then fifth, sixth, and seventh is going to be mostly Z's right now because there's no breakdowns, there's no other choices yet. These are the most important things. What are we actually doing? These are the abuse treatment root type, which is going to be your character 3 in your codes. What are we doing for the patient? Detox, individual counseling for substance abuse. Again, you can see how important it is to know if they're having therapy, group, family, or individual, what is it for? Is it for a mental health issue, or is it for substance abuse? So that's going to make a determination on which code is most appropriate. Then you also have the medication management and pharmacotherapy. I think those are so close together, it's sometimes hard to know which is which, because actually pharmacotherapy is treatment using medications. So we may have someone who are starting the treatment there, like they're coming in for a special type of treatment. We're trying to do a detox, and so we're going to give them methadone, for example. That's when we're starting it. We're actually going through the therapy. You're going to use the pharmacotherapy codes. Once they're on the medication, and maybe they're coming, or we're just checking to make sure that the the medication is at the right level, that's when it typically switches to medication management. So those look very similar to each other when you're looking at those codes. Character 4 is going to be the type qualifier. Again, not all types are going to have that. And here are some examples when you do. When you go through pharmacotherapy, specifically what is it we're using? Nicotine replacement therapy, methadone, and then there's other types as well. So that's the thing that typically is found in the chart documentation, but we need to know what type of qualifier, what type of pharmacotherapy we're actually doing for the patient. So it can be real specific there as well. Okay, and this just shows you I went under pharmacotherapy for substance abuse, so we're using medications to treat, and then you can see if it's anti-abuse, there's the code. If it's methadone, there you go. If it's the naloxone, there it is. So again, it's got different choices there. But there again, you can see instead of most cases like up here, you can see it gives you the 3 or 4 characters, but down here it gives you the whole entire code. So they're pretty easy once you find the name of the medication. It usually is going to be very easy to find it. Here I looked up detox. I just put in the word detox. You don't even have to put in the full term with TrueCode. So I just put in detox, and it says, okay, I think you mean detoxification services for substance abuse. There's your code. So it just gives me that one code, and it's very easy to find. So this would be really easy to put into cheat sheets, or, because basically there's not a lot of choices there. Now in some cases there are, so you want to be careful. Now I just wanted you to see what the tabular looks like in TrueCode, and this looks very similar to what it looks like in your paper code book. So you can see here the section is substance abuse. H, the body system is Z, because there's really not a body system. The type is detox services, and it gives me the definition here. I think that's very important to make sure I'm in the right location. The 4th, 5th, 6th, and 7th, there's no other choices. That's it. So it's pretty easy to find the codes in these chapters. Like I said, the main thing that I've found that throws people off is the difference between the medication management and the pharmacotherapy. When do I switch from one to another there? Well, I think that is all I have to tell you today. So I appreciate all of your being here with me today. I do think we have just a couple of minutes for any questions, so I'm going to see if we have any. Sharon, do you have any questions that I can answer based on some of the information I gave today?
There are a few questions. The first one is there a code for hoarding?
A code for hoarding. I don't have the code book in front of me right now, but that's a great question. I can look at that, and so we have what we're going to do with these questions after the presentation today. We'll go through and see if we can find answers for those, and then we will let you know. We will send that out to everybody. We'll give you the answers to these questions. So hoarding, that's a good question, so we're going to see if we can find one for that one. What's the next question?
The next one is also a coding question. What kind of terms should we look for? Should we be looking for with perceptual disturbances? Will symptoms such as chills, jitteriness, runny nose allow us to choose withdrawal with perceptual disturbances?
I don't know that there's a code for withdrawal with perceptual disturbances, but we'd have to look in the code book. So that's another one. Great question. We're going to do some research on that one, and then we're going to get back to you and make sure we can find the right answer for you. And again, we're going to send that out. All these answers we're going to send out to everyone once we finish the presentation. Okay.
Yeah, this is another one we might need to get back. If a patient has Alzheimer's, dementia, along with vascular dementia, do you add all these codes to the chart?
Yeah, and typically when you're going through the coding process, if the process says code also or code first, then yes, you do want to code everything possible. You want to get the most specific information that you can. And if it says to code multiple codes, then yeah, I would go ahead and code all the codes as appropriate. I would code them all together unless there was a note that said do not code these together. So it's probably the answer is yes to that you would code that, unless there's some kind of note in the book that said don't do that. So yeah, I think that's important. I think in the past we may have tried to use as few codes as possible, but again, remember now what we're trying to do is paint the best picture we can, and if the code book says code also, use additional or code first, then we need to do that.
Okay, got a few more. We work for a governmental mental health facility with a lot of late career providers who are extremely resistant to any change, and therefore ICD-10. Can you suggest any other carrots we might use to convince them other than money?
I wish we could pay everybody money. I wish they'd pay us money, right? That's such a great question, because I know a lot of doctors are very frustrated with the system, and they feel like it's just one more thing that the government is doing to try and keep from paying us. But I think what's important to remember with ICD-10-CM in particular is that it is a clinical system. It was designed by physicians, and so it is a way from a clinical perspective to better capitalize or better capture information. And I think also looking at your process as far as when they're picking their codes in the DSM system, how do you transfer that over? But then also, if you only get general information, you can still code those. So that is a nice thing. If you do have people that are resistant to trying to get more level of detail there, you can still code the general stuff. I mean, I hope you're not having to ever use the F39 code. It's there if we need it, but hopefully not. But I think that's the main thing, is just letting them know that it's a clinical system, and it's going to better capture the level of detail. We're not asking them to document anything that they don't feel comfortable in. If all that they can give us is symptoms, that's perfectly fine. We're going to be able to code those symptoms. But just anytime they can give us that level of detail, you can show it. The other thing you might be able to do is look and see if there are any medical necessity edits, like with your local carrier, with Medicare, with your Medicaids, whatever, and your major insurance companies, and look to see if there are any medical necessity where a less specific code would not be on the list, that it wouldn't get paid for, but a more specific code would. And then you can show them how that would impact their reimbursement if they continue to choose the real general codes and not give you the level of detail. They're not going to get paid for those. And those are probably going to increase as we move along further in the ICD-10. So like I said earlier, the more we can do now, the better off it is. And so try, bite-sized pieces with doctors. Every so often do, like every couple of weeks, give them a tip, on ICD-10, and not try to hammer it all at one time, but just pick some of your hot topics. Maybe even do a little bit of an auditing on like your top 10 diagnoses and give them an idea of what to look for. And also within your specialty societies, sometimes they're really good about giving some coding advice and some coding rules and things to help the physicians out as well. So those are just a couple of things that we find, and some doctors it works really well with. And again, I know sometimes we have the ones that say, nope, not going to do it, you can't make me, and that becomes a little frustrating. But I think most of them are pretty good in just wanting to know what we need from them and try to help us as much as they can. Thanks for the questions. Anything else? We got a few more minutes.
Okay, the next one is, you discussed code first rule. Can codes with code first rule be sequenced as the principal or first listed diagnosis?
Yes, the codes that say code first, that is designed to be first. They should be listed first on your list when you're going through. If you have 4 or 5 or 10 diagnoses, in the pair of the 2 that you're looking at, the one that says code first should always be sequenced first. And most of the time that's going to be your principal diagnosis again, but that's going to depend on why they're here. You use the first listed diagnosis. It's going to be on the inpatient side, if you're billing for the hospital, is going to be the reason after study that caused them to seek treatment in the hospital. So again, it's going to depend on what is actually going on. So if you got someone with like Alzheimer's with a mental disorder with it and behavioral disturbances, then the Alzheimer's always going to be listed first. So that yes, most of the time that answer is yes. But again, it depends on the reasons for their hospitalization.
Thank you.
Any other questions?
I think that's it.
All right, well, we're just about out of time. What we'll do, there was some really great questions today, and I really appreciate that. You can continue to ask questions. We will get back to you. Again, we will do in the next couple of days is we will put those together, and we will send those out to everyone so you'll get the answers. If we could find a code for it, there may not be a code, but we'll do the best we can in trying to find those based on, and again, always coding is based on documentation. So, we'll try to find if there is a specific code for that, but it always has to be verified by you in your chart documentation. So, again, we just want to be careful with that as well. So thank you so much for being with us today. We really appreciate it. We're going to try and do more of these educational type issues. I hope you enjoyed it today, and TrueCode does really value your being with us. And so again, if there's something we can show you, if you'd like to see a little more detail in TrueCode, just let us know, and we'll be happy to show you that as well and talk to you about how it can be helpful for you in your facilities. Thank you. Thanks, Sharon, for helping me out on the back end. Appreciate that. Thanks, everyone, and I hope you have a wonderful rest of your day, and happy holidays, Merry Christmas, or whatever you celebrate. We appreciate you and hope that you have a great holiday season. Thanks, and we will talk to you soon. Bye now.